Hello, I'm giving this lecture on Byron Calhoun and maternal fetal medicine in the West Virginia University in Charleston as part of the Matt Bulfin Educational Conference that was canceled. We're going to go ahead and produce it as a webinar, and it's being canceled because of the, as I see, the perceived hysteria over the corona beer virus, as I call it. I give you my disclosure first because that's important for our, as part of our CME. We do not have any commercial products mentioned in this lecture or any support by any vendor or agency or governmental grant. Also, just anything that's good belongs to someone else, and probably any of the bad things belong to myself. This is an apocryphal picture because I always think of if there are two patients in maternal fetal medicine, and of course, if you had a baby foot, you could see it would be likely that the uterus had abrupted. So therefore, this is more to get us in the mood or help us understand that there are two patients always. And we're going to talk particularly about the ability to treat the patient in utero. We'll talk about, for those of you who are very German, like my lovely wife, we'll give you historical perspectives. We'll talk about a little bit about the development of the fetus as a patient, and we're going to talk about the therapeutic options that are available today for the fetus in utero. The development of the fetus as a second patient were really brought about by embryology in the 19th century, also by some of the advances in moral personhood and the theory that has accompanied that. The first real probably breakthrough was 46 chromosomes by Dr. Lejeune with trisomy 21 as a source of Down syndrome, which is well known throughout the world. Then also because of the really phenomenal diagnostic ultrasound advances in the last 30 years, it gives us a wonderful view into the window of the womb, as we call it. And we're going to talk about this new science, which is the science of in utero therapy of the preborn. The first thing that was ever done in utero actually was Dr. William Liley when he developed in utero transfusions for RH or blue babies in the 1960s using fluoroscopy. He used that to be able to show that he could identify the abdomen of the baby, where he could then go ahead and take a trocar with a needle and instill red blood cells and transfuse the fetus and treat the anemia that was a result of the RH disease. Then we've now come further because we now have this wonderful tool of ultrasound. We can diagnose all sorts of anomalies and conditions and in utero that we can now treat with various modalities. I love this picture because it shows us the real personhood of the baby. We have a 3D picture of a baby's face in utero, which we can see now live and video real time now with the advancements that we have now in ultrasound and the ability of the technology to demonstrate the features of the fetus in a very graphic and very detailed way. Well, the first therapeutic option we're going to talk about is external cephalic version, and that's the turning of the baby from a breech presentation to vertex. This seems rather simple, but has actually increased the ability for us to decrease cesarean section rates and to also treat the fetus in utero and provide a successful vaginal delivery. The increase in success rates went from about 57%, as you can see, to almost 73% with the epidural analgesia, which relaxes the abdominal wall muscles and provides the relief from pain for the patient and allows us to have a much more humane way of taking the baby, turning it from breech to head down so we can have a vaginal delivery. We also have had several meta-analyses and systematic reviews done in 2011, and we noticed that the increased success rate was about 60% from about 37% to 38%, with a very robust analysis of the available literature. The problem with, of course, external cephalic version, the issues that we have with that is that it can be expensive because you have to hospitalize patients, you put them in the hospital in a bed, you have to provide the epidural analgesia, there's sedation, there's the possible effects of the epidural, which is maternal low blood pressure hypotension, and can lead to falsely abnormal fetal tracings and compromise to the fetus that are really a result of the procedure we're actually performing. There are also possibility of the prolonged effects that have possibly been brought up about the patient with regard to doing epidural analgesia and the sedation to the fetus. I like to show that I'm not just a paper saint, as we say, or a person who does not have a life. This is my son, Paul, with his lovely bride, Barb. Paul's my oldest son, and he's frankly serving now in the military. He's overseas in the Middle East, defending our way of life against all enemies, foreign and domestic, as I like to say. The new data on analgesia has come out for the external cephalic version, and Wang in 2017 published a novel approach for pain relief. What he did is he randomized 144 women, and he used a short-acting, basically opiate, which has very rapid onset and is metabolized by esterases, which is important because the fetus has the ability to metabolize anything that has an esterase attached to it. So these have a relatively short-acting effect on the fetus with a very, very short half-life, as you see, approximately 3 or 4 minutes. What he found was that they increased their success rate from about 39% to almost 57% in the treatment group, which is a significant ability for us to convert the baby from breech to vertex and allow vaginal delivery and prevent cesarean sections, which are of risk to mothers and also have adverse outcomes in the fetus. Babies that are born vaginally actually transition to life much more robustly and with less complications. And what he found was there was no difference in adverse events when he used this short-acting esterase. The next thing I'd like to talk about is looking at maternal anesthesia and ex utero, which is outside the uterus intrapartum treatment, and some of the exit procedures, which is basically intubating the baby after delivery. This is usually done following a tracheal clip or balloon for possible diaphragmatic hernias. It's also useful for cervical teratomas or masses in the necks, large hemangiomas in the fetus, goiters in the fetus, and also some neuroblastomas. Also quite useful for babies who have compromise of the lungs with a cystic adenomatoid malformation, or CCAM, or CPAM as it's called, cystic pulmonary malformation, and bronchopulmonary sequestration. There could be mediastinal masses as well, which are teratomas, and some of the lymphangiomas in the chest. There is a nice exit procedures with intubating the fetus and then transferring the fetus to extracorporeal ventilation, which is ECMO. This is done in the large fetuses with large diaphragmatic hernias, which have a very small lung to head ratio, meaning the lungs are quite small, with the liver up inside the chest with the malformation itself. Also, some of the congenital heart diseases with the hypoplastic left hearts, with restrictive atrial septums, and also some severe aortic stenosis with a very restrictive atrial septum. The diaphragmatic hernias and the lung ratios less than 1 to 2 are the patients who are very high risk for having issues in intubating the patient if you deliver the baby by a cesarean section and then allowing them to be placed on bypass, essentially. There's the exit to separation, and there's also tracheal and laryngeal atresia, which is the chaos malformation in which the baby actually has really no larynx, and you deliver the baby by cesarean section and then go ahead and perform a tracheostomy and intubate the baby on the maternal abdomen while the baby's still on bypass, if you will, or the umbilical cord. The maternal analgesia pitfalls are significant. This is a busy slide, but really talks about the inability to obtain adequate uterine relaxation, extra fluid. The fetal position is not adequate for the hysterotomy, failure to prevent bleeding with uterine staples, the failure to use deep inhalation analgesia and anesthesia to relax both the baby and the mother. We also fail sometimes to adequately maintain maternal blood pressure, which is critically important to this. Sometimes there's cord compression. You have to be careful of the umbilical cord so you're not impinging circulation to the fetus. Possible uterine abruption or separation of the placenta. Some people don't understand that you have to make the fetal airway a real priority. The airway challenge can be significant, so you have a well-trained team, basically a pediatric ear, nose, and throat specialist or a good anesthesiologist, possibility to allow time for return of uterine tone, so there's increased bleeding, failure to use an endotracheal tube of the proper type, failure to maintain the uterine volume with the fluids, and intrapartum fetal monitoring, and recognize the fetus's inability to tolerate the exit procedure. Critically important that we need to have a state of uterine hypotonia, so the uterus is not contracting, and maintaining uteroplacental circulation. As the uterus contracts, of course, it restricts circulation to the fetus, and this can be a real problem. Preserve the uterine volume with fluids so you can prevent placental separation early on. A deep plan of maternal analgesia and anesthesia, but maintaining normal blood pressures, and inability to obtain a surgical level of fetal anesthesia without depressing the fetal cardiac status itself. And also, we need to make sure we displace the uterus to the left side to keep it off the vena cava so that we have good perfusion to the fetus and to the maternal uterine bed. They use rapid IV sequence analgesia with thiopentanol. You use succinylcholine on the fetus to keep it from moving or paralyzing it. Fentanyl for pain relief to keep the baby's heart rate down and maternal uterus relaxed. And the maintain your paralysis of the fetus with the vercuronium titrated by actually testing the fetus and the mother with peripheral nerve stimulation when available and possible. Again, this is Paul with his daughter Katie, which is his daughter. She's my oldest grandchild. And here they are in front of their house showing them on a lovely spring day here in West Virginia. Inhalation anesthesia is maintained by mask assisted ventilation with a minimal alveolar concentration of the gases that we would normally use, and then increase it to 2 max before maternal incision to get deep anesthesia. There are also tocolytics to prevent uterine contractions. We can use nitroglycerin, terbutaline, which is a beta mimetic, and also indocin is quite useful as well. The prevention of atony or the uterine relaxation at cord clamping is to decrease your analgesia to 0.5 or off and lighten the anesthesia available. 20 units of Pitocin to try to keep the uterus from becoming very boggy and bleeding. Also, sometimes we give Methergin IM, never IV, because of the possible arterial effects and possible necrosis. And you can add carboprose, which is a alpha prostaglandin as well to keep the uterine tone adequate. Maternal volatile anesthesia is used. It may take quite some time to reach very high levels for the maternal vascular beds and the maternal analgesia. Prior to fetal incision, use fentanyl to relax the patient for pain relief and also for the fetus to give the fetus pain relief, and atropine as well to provide dry secretions, and vancuronium to the fetus and to the maternal circulation to keep the patient immobile so that you can have an adequate level of paralysis so the patient's not moving when you're trying to perform these procedures. Therapeutic options that are available to us now, after we've talked a little bit about some of the exit procedures, are GU anomalies, hematologic disorders, infectious disease, GI anomalies, pulmonary anomalies, neural tube defects, vascular anomalies, cardiac anomalies, kidney or renal anomalies, skeletal anomalies, and some of the genetic disorders as well. So if we look at the GU or the urinary tract anomalies, there's bladder outlet obstruction is one of the common ones we see. Usually it's from incomplete cannulization between the pelvic and distal uterogenital sinus early in development. The incidence is more common in males, in approximately 1 in 5,000 to 8,000 males. Not particularly common, but common enough so we see several cases of this every year. The babies usually die from pulmonary hypoplasia because you need the fluid from the urine, which is one of the primary components later on after 18 or 20 weeks, to enhance development of the type 2 alveoli. You need that hydrostatic pressure. Fetal urinalysis helps us provide a prognostic ability to figure out what babies may or may not benefit from this therapy who have some renal function that remains. This is a classic bladder obstruction. It's called the keyhole defect. For those of you who are under my age and some of the rest of us who are a little more mature, who don't really even know what a key is, this is the classic key that you would place in a door to unlock it. It's called the keyhole bladder. You can see where the star is. That's the urethra dilated proximally, and there's an obstruction distally, and the bladder, of course, is unable to empty because of this obstruction in the urethra. This is a spontaneous decompression of the bladder by the baby in utero with a rupture of the bladder with urinary ascites, which is a quite concerning sign because this bladder has been overdistended and affected the kidneys as well as the bladder itself. When we look at urinary biochemistry, this gives us a prognosis. And what we do is we look at the sodium, the chloride, the osmolality, and these microglobulins and the calcium. The fetal urine is hypotonic compared to what would be in adult life, and we can look at that and give us a prognostic ability to tell what is going on with the function of the kidneys at the time we are tapping the bladder. When we do our bladder taps, we use at least 3 sequential urine samples, as you've noticed, 48 to 72 hours apart, and we're looking at a urinary sodium, chloride, and osmolality and beta-2 microglobulin that are low. This tells us that there is retained urinary function, and that if we do a shunt to try to bypass the obstruction in the distal urethra, that we would have a good outcome. This does not really necessarily solve the problem of the renal dysplasia, but does help prevent pulmonary hypoplasia. There's still this very high 33 to 50% risk of renal failure in childhood. There is a possible role for renal biopsy in the fetus as well, although this is not as commonly utilized as tapping the bladder sequentially with a needle placed through the maternal abdomen, similar to an amniocentesis. Again, we know that the renal pelvis being dilated greater than a centimeter is really a non-favorable. We notice that unfavorable prognostic factors are severe oligohydramnios, increased echogenicity and cystic changes of the kidney or cortical cysts, and the abnormal urinary electrolytes. If you look at that, high levels of sodium, chloride, and osmolality, and beta microglobin are very, very poor prognostic signs that these kidneys have any function left available to you when you shunt them. Here's the example of what we use. It's called a rocket catheter, which is the company who makes this. As you notice, it's a dual pigtail catheter, and the reason you use a dual pigtail catheter with this trocar is that then once you place this catheter in the fetal bladder, that it cannot be dislodged by the fetus. Although having done this over many years, the fetus, once he recovers or she recovers from the analgesia, generally the male, they will actually notice that there's a foreign object and they can actually remove this catheter in spite of your best efforts. Here's a nice example showing how we place the ultrasound on the maternal abdomen. We use the trocar and a catheter with a pigtail and use an introducer and put the catheter under ultrasound guidance in the fetal bladder and straight, and then of course it unrolls the pigtail one side and the other side is outside of the fetal abdomen so that we have open access to the amniotic cavity. Again, ultrasound examination, we notice that the prognostic evaluation is the most important part. That's the large circle in the middle, looking at renal function. If it looks like we have adequate renal function after multiple taps, then this is more likely to be a successful outcome for this fetus. Looking at megacystis, or very large bladders, there was a study done on 284 cases, and they looked at bladder diameter greater than 7 millimeters in the first trimester and incomplete emptying of a large bladder in the second and third trimester. What they found is that of these early cases, about 40% resolved before birth and didn't require anything. The late cases, being the second and third trimesters, only about 12% resolved and didn't require anything. Cases without resolution prior to 23 weeks almost always ended up with significant urologic issues and renal failure. If we look at isoimmune eye drops as our next therapeutic option in hematologic disorders, we've noticed that this is a really outstanding example of the science of triumph of treatment of these babies. It went from 43 per thousand samples in 1967 to 2.6 per thousand samples after the introduction of Rh immune globulin at 28 weeks, because they knew that 1 to 3% of fetuses would be sensitized at 28 to 30 weeks. If we treated at 28 weeks, it's less than 1%. Interestingly enough, we noticed that if you look at the Rh negativity of patients, that 15% are of Caucasian or European descent. In fact, if you look at the Basque people in northern Spain, up to 85% of them are Rh negative. 8% of African Americans, approximately 8% of Hispanics, and less than 1% of Eskimos, Native Americans, Chinese, or Japanese are Rh negative. This is ascites with severe hemolytic disease and high drops. You can see that there's this fluid around the bowel, indicating that this baby is already starting to go into high output failure as a result of the anemia from the hemolysis of the red cells by the antibody in the fetal hemopoietic system. Therapeutic options, again, we've tested for Rh antibody. The critical titer is actually from 1.8 to 1.32 for Rhd immunosensitivity. You need a fourfold rise from the baseline, so you do titers approximately every month. If there's a fourfold rise above 1.8, actually 1.16 with Rh, then we know that we have a problem. We can also test paternal Rh status and zygosity. If the father of the baby, who is deemed to be the father, is Rh negative, then this fetus is obviously not at risk. You can also do fetal blood type amniocentesis, and there also is now cell-free DNA that's being used on the maternal side to test for fetal DNA to determine whether this baby is Rh negative. We see scalp edema with severe hemolytic disease. Again, this is a very grim prognostic sign, and these fetuses need in utero transfusion. We used to do amniocentesis for these titers, looking at a curve from 18 to 22 weeks gestation to determine if we had critical values necessary for transfusion. Fetal blood sampling was then used to determine a hematocrit less than 30% or 2 standard deviations below the mean for gestational age. The hematocrit of a fetus is between 50 and 60% on the average. We now use ultrasound less than 35 weeks. We use a peak middle cerebral artery velocity because we can use that artery that is trapped inside the fetal head, and we can actually do a ultrasound that gives us a perpendicular view of that artery. Therefore, the cosine of that is 1, which means we're able to then do an actual velocity. If you don't know the cosine of the angle of which you're inseminating, you're unable to do that and use a ratio. However, we are able to do the velocities, and it's really basically obviated the need to start doing any amniocentesis, which I did multiple, which were miserable for everybody because we did multiple amniocentesis every week, and it was just very, very uncomfortable for the patients and required a lot of effort. An artery velocity is much better, much easier, very easy for the patients, quick, and it's very, very accurate. Greater than 1.5 multiples of the median tells us that this fetus has been affected and would be a candidate for possibly in utero transfusion. Intravascular transfusions are not done for fetuses as early as 18 weeks, and I've performed these. They are necessary when the Doppler or amnio data, now Doppler data, shows us the baby is liable to be anemic. You enter the cord at a placental insertion site if possible, because if you're trying to do a amniocentesis or a cordocentesis, excuse me, to try to test that cord, if you will imagine a fork in a pan of spaghetti, it's virtually impossible to hit the cord in a piece of loose cord. Therefore, using it in the placenta where it's set is much, much easier. You do an opening hematocrit and transfuse to a hematocrit of 35 to 40% you've calculated. Hematocrit degrades by approximately 1% a day, so multiple procedures may be necessary. Use very high hematocrit, 75 to 80% hematocrit maternal blood usually irradiated and or glycerated and CMV-free blood. So most babies would deliver between 35 and 37 weeks with your last transfusion, approximately 30 to 32 weeks. Here we see a needle that is getting ready to go into the cord for transfusion, and that brightness that you see below the tip is really where you're going to be transfusing the blood into the umbilical artery. The next in utero infection we're going to talk about, or therapeutic option, is possible toxoplasmosis and parvo B19 or slap cheeks disease, if you will. Most people are already immune to parvo B19. It's not a rather large player. Toxoplasmosis is not that common in our country because, unlike the French, we don't eat raw hamburger or steak tartare. Toxoplasmosis seroconversion may take 1 to 4 months and carries a risk of infection in the fetus, as noted. Much lower in the first trimester as the placenta blocks the infection of the toxoplasmosis, 25% in the second trimester and 65% in the third trimester. Everybody worries about being exposed to toxoplasmosis with cats. If you own a cat for more than a few years, you probably are already immune. The cats who are indoors are not at risk for toxoplasmosis. It's those who are outdoors. They kill small animals such as mice who are a vector, and then they transmit the toxoplasmosis infection via their feces and cleaning the cat box. However, if you've already had a cat for multiple years, you probably already are immune, and we can actually check for that. Doing a test for IgG, if you're already immune, it's not a problem. Myeloscites and a pleural effusion in a baby with parvo B19. Diagnosis of toxoplasmosis, again, is by IgM, looking at acute infection, IgG, the previous infection. If you have positive IgG at the time in which the patient feels they've been exposed, they've already obtained immunity and are really not at risk. Fetal infection may present with the ultrasound findings of hydrops, cerebral calcifications, and liver calcifications. Diagnosis also may be done in the fetus by looking at PCR in the amniotic fluid, by looking for the toxoplasmosis itself with a PCR and DNA. Treatment in utero with antibiotics with spectinomycin and sulfas has been successful at least in one case of hydrops and has been used successfully for other cases of babies who are not as severely affected. Parvo 19 is more common than previously thought. and has actually been documented perhaps in 10 to 15% of previously undiagnosed cases of hydrops. Again, you can look for previous infection by doing an IgG or IgM. If you have IgG, you've already been previously infected and are immune and don't have to worry about this. Viral transmission is about 30% with active infection, usually presenting with the red cheeks and a low-grade fever and an exposure. The risk for fetal death is 5 to 10%, so the risk of infection is about less than 1% for fatality. Hydrops is a result of the bone marrow suppression by the virus so that the red cells aren't made and the baby goes into high output failure. Again, if you look at chordocentesis, you can do it as you notice at the top left in the base of the cord. You can also try to go in the cord a little bit farther out the upper right, and also if the placenta is posteriorly, you can try to go into the at the bottom image, go into the cord insertion site posteriorly. Much more difficult. You have to get by the fetus, and it's a lot farther distance to go, so it requires much more precise manipulations. You can diagnose parvo B19 by an IgM indicating acute infection, and then follow with serial ultrasounds for approximately 8 to 12 weeks. Realistically, if you have a possibility of infection, 6 to 8 weeks of ultrasounds looking at middle cerebral artery Dopplers really does rule out the possibility of infection and the ability to need to use it in intravascular transfusion. Survival after intravascular transfusion is much higher versus observed survival. We talked about some of this, looking at open fetal surgery. It's a busy slide. It talks about a lot about fetal anomalies and selection. We're going to move on. Again, twin-twin transfusion is one of those things we've used laser to prevent. We have twin reversed arterial or trap perfusion sequence, which we sometimes have to look at the pump twin versus a other twin going into congestive failure. Selective growth restriction. We've talked about lower urinary tract. We've talked about CCAMs. We'll talk a little bit more about some of these other heart anomalies as we move through our slides. Indications for the exit procedure, which we went into detail earlier, is there is extrinsic airway compression, which is the teratomas, the masses that are compressing the airway of the fetus. Some of them also are intrathoracic airway or persistent mediastinal compression, which is the pulmonary airway malformations, bronchogenic cysts, thoracic or mediastinal tumors. Severe cardiac compromise is the exit, which we talked to ECMO, which is extracorporeal perfusion. These are the poor prognostic indicators of hypoplastic left and or with the atrial septum restriction with the aortic stenosis. And then there's the bridge to separation, which are the cojoined twins, which are seen very rarely. If you look at congenital diaphragmatic hernia or GI abnormalities, it occurs in approximately 1.1 to 4.5 in 10,000 live births, so perhaps in the normal unit once or twice a year. Male to females are equally effective, which makes sense because it is actually a lung malformation. Left-sided is much more common than right-sided because the liver is on the right side, and that prevents many times this from happening. Right side is much smaller, and bilateral even less common at less than 5%. It's unknown in etiology, but it's failure of the closure of the pleuroperitoneal canals, which come in from approximately 4 or 5 different areas, fuse to allow the trachea and the aorta and the vena cava to transverse from the abdomen to the chest. It's diagnosed antepartum by a fluid-filled area in the chest, which should not be there, which is why on ultrasound we look at every fetus and look at the diaphragms to make sure they're intact and there's nothing in the chest except the heart and the lungs. Here we see a right-sided diaphragmatic hernia. The liver there is on the left-hand side, and you can see the heart, and there's a mass superior to the heart, which should not be there. Again, a left-sided diaphragmatic hernia, most common. The heart is to the right, as you see, and you see the stomach up in the chest with the liver as well, where they're not supposed to be. The mortality in unselected cases of diaphragmatic hernia can be as high as 80%. Prognosis we know is related to the size, which of course makes sense. Diagnosis less than 24 weeks, which of course shows us is much more severe. The liver above the diaphragm is significantly linked to survival. Liver above the diaphragm is about 43%, about 53% end up on some sort of bypass. Liver below survival is very high, 93%. The ECMO rates are very low. The other thing that shows us is a small contralateral lung, which means you have a much larger mass, compression of the lung, less ability to ventilate the fetus. Also, we know if you have associated anomalies such as cardiac and or neural tube or other things, it obviously shows a much more severely affected fetus, and bilateral is very, very serious. We look at the tracheal clip for diaphragmatic hernias. This was first developed, and what essentially was done is the fetus is located by ultrasound. The trocar is placed in under visualization, and a clip is placed across the trachea. The skin is opened up, and there's a tracheal clip placed. The idea is that as the lungs grow and the fluid comes from the lungs as a major part of the fluid in the utero, and for development of the lungs, that this would then expand the lungs and grow the lungs so that they would also get larger and slowly push that hernia back down into the abdomen and not do it acutely, which of course causes some problems with the vasculature. Here we see a tracheal clip with a string at the arrows to try to treat a diaphragmatic hernia. Originally we tried open repairs in utero, which we talked about briefly in the last few slides, with very success, but often there was a kinked umbilical or portal vein which caused death. There was an NIH trial at San Francisco to look at tracheal occlusion using a video fetoscopic technique and then do an exit procedure to try to deliver the baby, remove the clip, and then intubate the baby. And this is again looking at the ex utero. You deliver the baby through the lower uterine segment. You access the cord to monitor the baby. You then put a Broviac catheter in case you need to do extracorporeal circulation, and you open with a tracheotomy and do an endotracheal tube. There's a study of 14 severe cases with fetal tracheoscopic occlusion. They had looked at this and saying that they had 14 severe congenital diaphragmatic hernias with a very, very low lung to head ratio. What they did is they looked and put a balloon in. They took 12 of the 14 were left-sided, again, most commonly. Occlusion was done at about 28 weeks. They also gave these babies mother steroids and gave the mother's vaginal progesterone to try to prevent preterm labor. What's interesting is they delivered over half of them at greater than 37 weeks, which is a significant delay in delivery compared to the old techniques, and 86% of these babies survived to discharge. What they found is that the historical rate of survival is 42 to 50%, and they found that there was no delivery greater than 37 weeks with the old methods. Using this new balloon and placing it in the trachea, they were able to get much better outcomes. They also then were able to deflate these balloons by using a needle rather than having to do surgery, which was much less invasive and provided them much less of a risk for preterm labor. The next anomaly we're going to talk about is called congenital cystic adenomonoid malformation, or congenital pulmonary adenomyoid malformation, or CPAM now. It's a pulmonary lesion that's a cystic mass. They're usually unilateral, but may involve either lung and any lobe, but usually isolated to only one lobe and usually one segment in about 95% of the cases. Very rarely we see it at approximately 2%. We have a very sophisticated way of defining these: macrocysts, medium cysts, and microcysts. You see on the left, it's the macrocysts. B is sort of the medium or mixed, and right is the small or microcystic form of this disorder. They appear as mixed or solid cystic masses. We see them quite frequently at 16 to 20 weeks. The good news about this particular malformation is most of them are gone by the third trimester. If they regress, or you are not able to see them very well by the third trimester, after 28 to 30 weeks, virtually 100% of these babies survive and do very well. High drops is a very poor sign, and if they're treated expectantly, virtually all of these babies die. A mediastinal shift is a very concerning sign because that will compress the vena cava and the aorta and or other vascular the other vascular parts of the fetus. We would then attempt to tap a large mass in utero, and I myself have even placed an indwelling double pigtail catheter, just as we did for the urinary masses. You may need to have an in utero resection with an open procedure in a very small number of patients, particularly those who are perhaps hydropic or have a very large lesion. They have a 61% survival if you do an in utero resection versus 100% mortality if you do not do anything with these large masses and high drops. Study looking at prediction of respiratory distress. There's a small group of patients, because this is not as common as other malformations, looking at 47 cases. The volume of the lesion was looked at, looking at the MRI, looking at a maximum volume of the lesion greater than 24 centimeters. It had a very high sensitivity and specificity. Looking at ultrasound, maximum volumes greater than 34 centimeters had a very high specificity and sensitivity for good outcomes. This is a rather large cystic hygroma with multiple cysts and microcysts. You can see the bright area. And superiorly, that is the microcystic portion. You can see the macrocystic, and you can see this really largely shifted heart over to the left side of the chest. Again, we have our friend the rocket catheter, very similar to draining the fetal bladder, and we use a double pigtail catheter, and we do the same procedure with ultrasound and a trocar and the catheter. We see here there's a fetus with a rather large cystic adenoid malformation and ascites, and you can see the cystic areas involved in this. Next, we're going to talk about neural tube defects, which is one of the great triumphs that we've had with in utero surgery. It occurs roughly in 1 in 1,000 pregnancies, probably more like 1 in 5 to 600, since now we've gone ahead and gone folate supplementation in virtually everything that is purchased now, and all our cereals and all other things have folate in them to decrease the incidence of this particular malformation. We know that's related to folate deficiency. The incidence is reduced again in about 50% with 400 micrograms only a day preconceptually in women without risk factors. So we see adding just merely small amounts of folic acid to the diet has basically allowed this malformation to become very, very much rarer. It's approximately 1 in, I think it's 1 in 5, 1 in 2 to 3,000 pregnancies, much lower. If you've had a previous child with a neural tube defect or a family member, you need 4 milligrams a day of patients, or for patients who've had a history of family with a neural tube defect. We diagnose them often originally by elevated MSAFP. It's also seen in ultrasound with the classic signs of the lemon side of the fetal head with collapse of the cerebral hemispheres and the actual tethering of the cord and the pulling posterior of the brain. You also see a dilated posterior fossa with the Chiari-2 type malformation as you obstruct the spinal canal and get posterior fluid in the cerebellar region. Also, then we see an open neural tube defect by ultrasound on the spine. Anencephaly is lethal with no cerebrum. Spinal bifida management is variable. We did a nice study called the MOM study, or management of meningomyocele. There were 3 sites, and we wanted to see if surgery actually changed outcomes. What we found is we had the criteria. The highest lesion was T1 through S1, so no really high thoracic and or cervical. There was hindbrain herniation with Chiari-2 malformation. You had to be 18 years or older to give consent, and you had to be between 19 and 25 weeks. You also could not be obese. You could not have any hepatitis C, HIV, or drug use, because these patients were not considered to be able to be included in this particular study. You couldn't be a non-resident. You couldn't have a twin or triplet pregnancy. You couldn't, again, as we said, obese. You could not have abnormal karyotype. You could not have a cerclage planned at this point in time, although now many people do actually put a cerclage in for these patients. There's no history of spontaneous preterm labor. Again, we talked about infectious problems, uterine anomalies, or unable to do the follow-up and or live in the area that you're being asked to do the surgery and or study. I like to have pictures again of my son. This is my son Paul getting ready to do an egress out of a helicopter in the Army, as we say, hoo-ah. This trial was stopped in 2010 because we had already noted that by looking at the efficacy analysis, we had 78 and 80 patients in 2 different groups. There were 2 primary outcomes, both shunting and mental and motor function. The most significant finding was that there was no shunting necessary with prenatal surgery, about 40% versus over 80% with postnatal surgery. There are also improved composite scores for mental and motor development with prenatal surgery in utero compared to postnatal. The secondary analysis for ambulation also improved in those who had the surgery. The other thing that was looked at was looking at urinary and fecal continence, which were much improved in patients who had in utero surgery, which is a very, very big issue for any patient's families who have to deal with these babies who have had a meningomyocele. Ambulation without orthotics was improved to 42%, which is an incredible advance for patients who've had a neural tube defect. Surgery on the patients, of course, increase your risk for preterm delivery because you are operating on the uterus, although this has decreased significantly since now we're doing actually laparoscopic procedures with much smaller instruments and not doing open procedures to repair these defects, thanks to the advancement of laparoscopic and or other surgical procedures. We're next going to look at sacrococcygeal teratoma, which is the most common tumor of the fetus and the neonate. However, it is extremely rare. I see one of these perhaps one every few years. The malignant invasion is extremely rare for these. They're basically a vascular tumor that has developed and are not malignant. Mortality is usually due to high output shunting with heart failure and high drops with placentalomegaly, right? Also may produce a mirror syndrome with maternal findings that appear to mimic severe preeclampsia, which if you treat this particular tumor, those signs and symptoms go away in the mother. The sacrococcygeal teratoma are categorized according to classification by the American Academy of Pediatrics surgical section. Type 1 is external with minimal presacral component. Type 2 is external but has some intrapelvic component. Type 3 is intrapelvic with abdominal extension. And type 4 is entirely within the pelvis and the abdomen, which is fairly rare. These are pictures of a sacrococcygeal teratoma. The upper left-hand side on your screen shows the cystic area with the solid and cystic component. The right side shows this involvement against cystic and solid component at the base of the spine. The lower left hand again shows the significant evidence of the cystic component and solid, and you can see the solid component with cystic areas on the lower right hand part of this picture. The Doppler flow in these is quite high. If you look at the blood flow, it shows that there's significant high flow to these particular lesions. We also do Doppler flow, where you can see on the color flow in the upper left and the upper right, showing very, very high flow velocity by the power Doppler. And if you look at the Doppler velocities on the lower right picture, very, very high at 90 centimeters per second, showing extremely high amounts of shunting and high flow to these particular lesions. This is an MRI showing with the large arrow showing this large cystic hygroma, which is as large as the baby's head, so probably 7 or 8 centimeters. These may be diagnosed as early as 14 weeks gestation. I've seen them actually probably about 18 or 20 weeks is probably the earliest I've seen them. They're an intra-abdominal or caudal mass. They light up like a Christmas tree, quote unquote, when you put the power Doppler on them. They may be cystic, solid, or mixed. The differential includes renal, ovarian, or myelomeningocele, and that sometimes can be difficult, particularly for a neural tube defect, but the spine appears intact, and you can see this as a separate lesion. Doppler flow with the high flow really tells you that this is a vascular lesion and helps you in the diagnosis of this versus just a cystic mass, such as a neural tube defect. Careful monitoring is necessary, and you may need to do in utero intervention if there's failure of the fetus that presents as part of the syndrome. We also have seen some possible ablation of these feeder vessels with radiofrequency ablation. There's been a small number of studies, but it perhaps may be superior to resection. If you look at the sacrococcygeal teratoma, they do a very nice diagnosis in Philadelphia at CHOP. There's no high output failure. You do serial sonography. You do an elective delivery, term, and early cesarean section if there's extra fluid, and repair it after delivery. If there's high output failure, they may need to do emergency cesarean and or they may need to do fetal surgery. Here is a baby at approximately 26 or 27 weeks. You can see the umbilical cord. You can see the sacrococcygeal teratoma there to the left, which is almost as large as the baby itself. This child was starting to go into failure. They resected this child, delivered after 37 weeks, and did very well. If you look at a review recently done on 32 cases of minimally invasive treatment of fetus with solid tumors, they had a 44% overall survival rate. They had a 30% survival of children with high drops, which is very high. They did laser ablation 1. They did survival with laser radiofrequency 5 of 11, and 8 of the 12 without high drops survived. They looked at 12 cases of open surgery, 11 of the 12 cases with high drops, and a much higher number of them survived because, of course, they're able to remove the fetus and not have all the different coagulopathies and other coagulation type compounds that would happen if you coagulate and or clot off any sort of a mass with release of cytokines and other coagulation factors. There's a study by Instrument in 2017, which 112 cases they had 73 neonatal repairs, less than 30 days of life, 33 repairs greater than that, and they had 6 in utero repairs. What they found is that they had, in utero repairs, they had 1 operative mortality, and they had 30-day mortality, 2 of the 6. Of the intraoperative mortality was 1 of 73, and 5 at 30 days, and they had no mortalities intraoperatively greater than 30 days, and none after 30 days. So in utero therapy are the sickest patients and would therefore be the ones that are most high risk of loss of the pregnancy. They concluded that preterm delivery less than 30 weeks at the time of surgery had increased mortality. No surprise there because of the prematurity issues. Solid tumors needed more transfusions. Again, no surprise there with higher blood losses and increased mortality rates. Hypoplastic left heart is the next thing we're going to talk about. It's usually a result of aortic or mitral dysplasia or atresia, maybe an autosomal recessive. The recurrence risk is about 4% with 1 child, 2 children as high as 25%. You look at this, the hypoplastic left heart is seen there in the lower portion of the picture, normal right atria, left atria, and a hypoplastic left because of mitral and or aortic stenosis. Again, if you look at the ventricle, left ventricle is much smaller than the right, and it should be the same size. Again, with backflow, you can see backflow with the Doppler. You can see tricuspid regurgitation, which it should be going forward. If you see the vascularity going inferiorly, that's tricuspid regurgitation. Basically, in hypoplastic left heart, you show a very small left ventricle. There's either an absent or small mitral valve or aortic valve. The prognosis is worse with a smaller the ventricle. Therapies include after delivery, a Norwood procedure in 3 stages to reconstruct the left ventricle, and a Fontan to connect the left atrium, to the tricuspid and right atrium to the pulmonary artery. We've had the latest attempt is in utero therapy, which involves placing a catheter, perform a valvuloplasty to open up that small mitral aortic valve. There's still not a lot of good data on this, and it's still under protocols at most places. Tachyarrhythmias are pretty uncommon. 8% of the fetal rhythm disorders are tachyarrhythmias or supraventricular tachycardias. You would treat them before 32 or 34 weeks. After that, you would deliver the baby, do an external pacer perhaps, and or treat it. Utilizing the first line therapy is digoxin or flecainamide. Second line therapy is verapamil, procainamide, quinidine, and propranolol. Intravenous therapy to break the tachycardia after loading with digoxin. You would use some sort of a adenosine to do that to try to stop the tachycardia. Fetal bradyarrhythmias, fairly rare. Most of the common with structural defects like atrioseptal defects or ventriculoseptal defects. The rate's less than 55, and you'll need a pacemaker after delivery. You also may need to detect for possible connective tissue disorders with Sjogren's syndrome, type A antibodies, or Sjogren type B antibodies. These fetuses will require pacemakers after delivery, and probably pacemakers for the rest of their lives because the conduction system is destroyed by the antibodies. Here's my little granddaughter Penelope with her pig, and she's modeling that for us to show us Penelope the pig. Renal anomalies are limited because they are usually caused by outlet obstruction. The therapy is usually the same as an outlet obstruction. You check the bladder, you look for renal function, and see if the possibility of this kidneys can be resolved. If not, these fetuses will be born and may need some sort of a either transplant or they may need dialysis. Skeletal anomalies, there's really no skeletal anomaly therapy except at this point except for spina bifida. If you look at maternal complications to open procedures, we're going to talk a little bit about those because I think they're important to mention that this is not without risk. It sounds wonderful to be able to do spina bifidas, to do diaphragmatic hernias, to do these things on the bladder. Pulmonary edema is very common. Partial or complete scar dehiscence is quite common. Uterine rupture is very common. Abruption is not uncommon. And infection are also quite common. So you have to be aware of all of these complications and share them with the patients who are willing to undergo possible fetal therapy to help save their baby's life. You can see leakage of fluid. Again, abruption for these are fetoscopic procedures are a little bit lower because you have a less of an invasive procedure. Chorioamnionitis and twin-twin transfusion, chorioamnionitis for spina bifida, pulmonary edema for twin-twin transfusion, and pulmonary edema for spina bifida because the surgeries are shorter, involve less fluids, and are less invasive. Another thing that we can actually treat is combined immunity syndrome, which is called SCIDS. It's an X-linked recessive or autosomal recessive, or perhaps sporadic. It's absence of both your B and T cell immunity. Your death is usually by viral or bacterial infection within about a year of age. These are the bubble children. We think it's a failure of the hematopoietic stem cells to develop. The fetus is immune incompetent. Therefore, you're able to transfuse maternal stem cells without a graft versus host rejection, which is usually, the fetus is immune competent by 14 weeks, which is why most of our therapies that we try to use stem cells from the maternal side or others end up in rejection. You take maternal stem cells from the bone marrow and infuse them versus an intravenous transfusion through the cord at approximately 18 weeks. The fetus is born as a chimera with a mix of maternal and fetal cells and is immune competent and has a normal ability to fight infection. The next one we're going to talk about, which is rather unique, is Down syndrome as a model for a treatment of neurodevelopmental disorders, which is extremely exciting. We know that there is a phenotype which characterizes the disease. There's a genotype, which is the underlying genetics. There's an animal model which we'd want to develop, a possible phenotype of the animal, looking at underlying genetics, molecular biology, and neurophysiology, a therapeutic strategy based on biological findings in the animals, looking at drug development, and then clinical trials. So this is how we would talk about developing something for Down syndrome. We know that there's an alteration in the number and the density of the dendrites, the spines, and synapses in Down syndrome. We also note there's an alteration of the density of the neurons. We know there's a fetal and adult cortical lamination is reduced in the anterior cortex. There's hypoplasia of the hippocampus. There's also reduction of cerebellar size. There's degeneration of the basal forebrain. There's neurotransmitter alterations. There's impairment of the prefrontal cortex and the hippocampus. There's anxiety, hyperactivity, attention, and reduced sensitivity to pain. The deficiency in language and speech and articulation, low IQ and behavioral, and learning and memory impairments, which are all cognitive impairments to Down syndrome. Ultrasound findings in Down syndrome show that there's usually a small cerebellum and the frontal lobes are small. You may be seen as a brachycephaly or small, round head as early as 15 weeks, and restriction of the occipital frontal region, particularly in the supratentorial regions of the brain on ultrasound and MRI. So this is the ultrasound of the intracranial anatomy. You can see this relatively normal looking. The histological analysis is found in Down syndrome decreased numbers of neurons in the hippocampus due to decreased proliferation and increased death or cell apoptosis. Cerebellar volume is decreased by about 20%. There's also impaired histogenesis and cytogenesis of the cerebellum. There's also defects in proliferation of these particular cells in the hippocampus and the cerebellar regions. Down syndrome individuals reveal significant alterations in the dendritic and neuronal densities. There's a decrease in the number of the dendritic spines and receptors in the Down syndrome brain with decreased plasticity. The wow, that's a great word. Synaptic plasticity refers to the dynamic nature of synapses, which they're able to alter and change them and alter their function based on the stimulation and the way in which they're utilized. This is a communication area between the neurons and the function of the synapses, which respond in changes to network activity and training and how they're stimulated. Depending on the timing and the strength of these pre- and postsynaptic activities, they can either be strengthened or weakened, providing explanation for the memory formation and storage, so that if you learn to play an instrument early, you develop certain synapses different than those who don't learn to play an instrument early. Those who do certain things like reading or playing athletics, those synapses are strengthened and those pathways are laid down. Down syndrome have less of these and less ability to be able to respond and to change or modify their intracranial anatomy. We know that GABA is a primary inhibitor of neurotransmitters in the mammalian brain. There's three classes, A, B, and C. GABA A is fast inhibitory neurotransmission. GABA B is inhibitory slow. C is mediated slow and sustained responses, usually in your retinal and or horizontal cells. Down syndrome is thought to result in excitatory inhibitory imbalances. Alterations in your GABA receptors in Down syndrome impact the ability of the hippocampal structure, leading to the loss of GABA inhibition with neuronal cell death, which means you can't process your memories, you can't process data, you can't store it. Severe loss results in dysregulation and increased seizures also in Down syndrome. So you have increased excitability because of the disinhibition of the GABA receptors. The lack of glutamate causes the stimulation of your N receptors or the propionic acid receptors. Both of these induce cell death by calcium-dependent pathways. Thus, you lose dendritic cells and receptors, which also cause you then to have mental delay, memory problems, and seizures because you do not develop your spicules, your spines, your areas in which these neuronal receptors interdigitate and allow you to process memories and learning. Use of Down syndrome mice, which there are, revealed that there is treatment that's effective. If you use a non-competitive antagonist of GABA receptors, and the medications are picrotoxin, bilobalide, and pentyl-nitropterazole, and the use of non-competitive agonists of the NDMA receptors, which we talked about, memtamine and MK801, they show possible cognition in the Down syndrome mouse. There's my granddaughters. There's Katie and there's Penelope at Christmas in 2016. They're a lot bigger now. So the use of an active-dependent neuroprotective protein and fragments, an activity-dependent factor, and fragments showed improved function in Down syndrome mice. They used amphigenin in Down syndrome mice, improved outcomes without toxicity. Use of SSRIs, which is very interesting, which is a GABA inhibitor, does not seem to work in the mouse model. So what we look at in brain morphogenesis in Down syndrome is microcephaly, cerebellar hypoplasia, hippocampal hypoplasia, abnormalities in neurogenesis, synaptogenesis, and axon myelination. There's gene expression, which are crucial for brain development, for neuronal transmission, and neurocognition. Therefore, the template for Down syndrome is a template for other disorders, Fragile X perhaps, and Rett syndrome, both of which are caused by novel mutations in certain genes that are listed up on the screen. That's fall on my hillside. Beautiful area. West Virginia is a very lovely area. I have about 3.5 acres, and I live in a virtual paradise. Neurofibromatosis type 1 is the next thing I'm talking about in utero treatment. It's an autosomal dominant with a mutation of the NF1 gene. Tuberous sclerosis is another gene, obviously autosomal dominant. And then autism spectrum disorders are 1 in 150 in males. The template shows us that there's a new GABA inverse agonist in phase 2 trials. So if you can block the GABA receptors and allow them to allow development of the brain and the hippocampal area and of the areas within the brain for neurogenesis, you can actually help Down syndrome and perhaps provide in utero therapy to the mother to treat in utero Down syndrome and improve cognition. What about those patients who are terminally ill, those babies who probably have a very shortened lifespan? We do perinatal hospice, and this is called compassionate care, not abandonment.